So next question. In an obstetrics and gynecology clinic, a 28-year-old pregnant woman presents with right lower quadrant abdominal pain and fever. She is in her second trimester of pregnancy. Ultrasound reveals signs suggestive of appendicitis. Considering the diagnosis and patient's pregnancy status, what is the next appropriate step in the management of this case? So again, I would advise all of you that you should read all the options, because there might be some related options also. So it is important to find the one which is the best. And it is also important to refer the patient. For example, there was a question previously where the patient required an orthopedic consultation. So it should not be like, I'll tackle everything. What they are also assessing is, are you able to refer the patient when you feel that it is beyond your domain? Are you able to refer the patient to another department? That is also another skill which MRCOG exam is testing. And in this case also you require an urgent surgical consultation because the patient may require an appendectomy in this case, because again, this may result in complications if it is untreated, appendicitis. It may result in perforation, peritonitis, preterm labor. So all these things can be avoided if she undergoes an appendectomy. And that is a thing only domain which lies in the hands of the surgeon. So next question. In the ER, a 45-year-old woman with poorly controlled type 1 diabetes presents with severe abdominal pain, nausea, vomiting, weakness, and dehydration. She has a history of frequent insulin skipping due to financial constraints. Physical examination reveals lethargy and fruity breath odor. Lab test shows severe hyperglycemia, ketonemia, metabolic acidosis, and elevated lipase levels, suggestive of diabetic ketoacidosis with possible pancreatitis. What is the most appropriate initial management step for this patient? DKA again is a very, very important topic for MRCOG exam. Make sure you know about it in depth. This is an easy question. What's the treatment of choice? What should you do if you encounter a patient with DKA? Yes, you need to administer insulin. I was hoping that somebody should not write that we should call a diabetologist, because this is something which you can manage on your own. You start an insulin drip, because insulin therapy is the main mode of treatment of DKA, because it will take care of hyperglycemia and ketosis. Next question. A 40-year-old female underwent vaginal hysterectomy. Post-operatively, her urine output has been consistently 300 ml since the surgery. On examination, the patient appears lethargic and mildly confused. Lab results show a white blood cell count of 14, urea level of 9.3, normal sodium and potassium levels, normal hemoglobin and serum creatinine. Considering the clinical scenario and lab findings, what is the most likely cause of patient's altered mental status and abnormal lab values? So what do you think is the problem in this case? Can it be post-operative hemorrhage? It cannot be, because the hemoglobin values are fine. She has normal hemoglobin. Urinary tract infection, it could be because the WBC count is increased, so that there is some suggestion of infection. Hyponatremia, no, because the sodium levels are fine. Acute kidney injury, the creatinine values are fine, so it appears unlikely that this is acute kidney injury. Dehydration, again, the urine output has been consistently 300 ml, which is per hour. 300 ml, which is fine. So obviously it is most likely to be urinary tract infection. And some infections, they may result in slightly increased urea levels, and probably that is what is resulting in her altered mental status. So somebody is asking that fluid resuscitation is more important than insulin for decay. Yes, insulin is more important. You feel that her airway or breathing or circulation is compromised. In those cases, you may go ahead with initial resuscitation. But otherwise, again, the scenario may change. The question may change if she's not breathing well or if her blood pressure is going very low. In that case, you can go ahead with fluid resuscitation. But otherwise, in the scenario which is mentioned in this question, the first thing which you have to do is give her insulin. So coming to the next question. A 30-year-old female presents with severe left flank pain and hematuria following laparoscopic myomectomy. Imaging reveals an inadvertent minute ureteric injury during the procedure. The patient is hemodynamically stable. What would be the most appropriate next step in management of this patient? So flank pain, hematuria, laparoscopic myomectomy. During laparoscopic myomectomy, there is a possible ureteric injury. What should you do in such a case? There is ureteric injury, so what should you do? In such cases, you should preferably avoid the laparoscopic management, because if there is an injury, it is better you go ahead with open surgery. You do immediate surgical exploration and repair of ureter, and there should be a stent also placed so that it doesn't compromise the patency of the ureter. In a prenatal clinic, a 34-year-old pregnant woman presents with severe hypertension, proteinuria and oliguria at 30 weeks of gestation. She has a history of chronic kidney disease. Based on her clinical presentation, what is the most likely diagnosis of her condition? So a previous history of chronic kidney disease. Then what is the likely thing it can result in pregnancy? What is the likely diagnosis? It is acute tubular necrosis. Because especially with chronic kidney disease, it can result in acute tubular necrosis. This is the most common cause of acute kidney injury occurring during pregnancy. So ATN is the most common cause of acute renal injury during pregnancy. A 36-year-old woman presents with irregular menstrual cycle from the past 6 months. She also complains of hot flashes and vaginal dryness. Her follicle-stimulating hormone has been raised to greater than 40 international units per liter within 1 month of examination. What is the most likely diagnosis? Now, she is having symptoms which are suggestive of premature menopause. She's having hot flashes, she's having vaginal dryness, her FSH levels have been raised to more than 40 international units per liter. What do you think is the diagnosis in this case? Yes, premature ovarian failure, which is resulting in menopause before 40 years of age. During a clinical evaluation, a 32-year-old woman reports amenorrhea, galactorrhea, weight gain, fatigue, and low libido. Further investigations reveal significantly elevated prolactin levels. Given these symptoms, what is the most likely diagnosis of her condition? So in this case, what do you think is the most likely diagnosis? This is an easy question. Yes, this is a prolactinoma. Probably a microadenoma in the pituitary, which is secreting high levels of prolactin. Next question is, 28-year-old woman presents with dome-shaped ulcers on her thigh and vagina. While examining, it was observed that the lesions are firm, white to flesh-colored, pearly papules, and have a central umbilication. So central umbilication, what does it point to? Again, a very simple question. Yes, molluscum contagiosum. Because some questions you will just know the answer, and I will suggest that when you start doing your paper, the questions which you know the answer, you attempt them, and the ones which you feel will require some thinking, you leave them And in the second round, maybe you can address those questions, because that way you'll be able to manage time also during the exam. Which nerve primarily innervates the iliacus muscle, contributing to the role in hip flexion and pelvis stabilization? So again, a very easy question. It is the femoral nerve. Femoral nerve, pudendal nerve, sciatic nerve, obturator nerve. Make sure you know everything about these nerves. You will surely get some questions either related to its innervation or the branches or their origin. During a hysterectomy procedure, a well-circumscribed uterine lesion is observed, accompanied by symptoms of heavy menstrual bleeding, pelvic pain, sensation of pelvic pressure, and urinary frequency. It was subsequently examined microscopically. What is the most probable diagnosis based on this findings? So a well-circumscribed uterine lesion during hysterectomy, what do you think this most likely is? Yes, a leiomyoma, because this is resulting in typical symptoms of a leiomyoma: heavy menstrual bleeding, there's pelvic pain, there's a sensation of pelvic pressure. So a big mass which is resulting in pressure symptoms. There is increased urinary frequency because it is again causing pressure on the bladder also. So this is the leiomyoma. What type of hypersensitivity reaction is associated with Goodpasture syndrome? So Goodpasture syndrome, it is type 2 hypersensitivity. Now, talking about the various types of hypersensitivity reaction, this is a very important topic. So type 1, so most likely you will get one of the questions pertaining to hypersensitivity type. Type 1 is basically allergic type, and this is mediated through IgE antibodies. So any kind of allergic reaction, atopy, that is what is type 1. Type 2 is IgG or IgM mediated, and this is basically causing the activation of the complement pathway. And what are the examples? One is the Goodpasture syndrome, pernicious anemia, some kind of transfusion reactions. Type 3 is basically due to some small antigen antibody complexes which are formed. So this can occur in cases of SLE, glomerulonephritis. Again, this is very important because any of these could become a potential question. Type 4 is basically delayed cell-mediated reaction, which is occurring, and this is basically your Montooth's or the tuberculin reaction, and also contact dermatitis. Another thing which is very important, and you will surely get a question pertaining to that, is vaccines. So whatever is given in your course manual on vaccines, make sure you go through it. They will definitely have 1 or 2 questions pertaining to vaccines. Lepra reaction, from my point of view, should be type 4 because it is delayed cell immunity which is occurring. But lepra reaction, I don't think anybody is going to ask in MRCOG exam. Coming to the next question, in females, which hormone serves as the primary precursor for synthesis of more potent androgens such as testosterone and dihydrotestosterone? Again, this is slightly tricky, though it is not difficult, but it is a slightly tricky question. If you don't read it carefully, you might answer it wrongly. So the primary precursor of testosterone and dihydrotestosterone. So what are the main androgens which are there in a woman? dihydroepiandrosterone, androstenedione, and testosterone. This is in very little quantity. So main it is androstenedione and testosterone, which is there, and also dihydrotestosterone. Now, how are these synthesized in the body? So if you look at this diagram, you can see that DHEA is converted into androstenedione with the help of the enzyme 3-hydroxy steroid dehydrogenase. And androstenedione is converted into testosterone with the help of 17-beta dehydroxysteroid dehydrogenase. And this testosterone is converted to dihydrotestosterone with the help of the enzyme 5-alpha reductase. Because either of these steps could be one of the questions. And most importantly, androgens are converted to estradiol. Testosterone is converted to estradiol with the help of the enzyme aromatase. So these steps, all of these become very important. Coming back to the question, which serves as the primary precursor. So what was the primary precursor? It was DHEA. We saw in the chart that DHEA is converted into androstenedione and into testosterone. So androstenedione and testosterone are the more potent androgens which are present in a woman. In man, it is mainly testosterone, which is coming from interstitial cells of Leydig in the testes. So coming to the next question, a pregnant woman undergoes a routine prenatal checkup at 20 weeks gestation. The healthcare provider measures the distance from pubic symphysis to the fundus of the uterus, the fundal height, and compares it to a standard chart. Why is it important to use subcostal plane as a reference point when measuring the fundal height, especially during the second and third trimester of pregnancy? So what is the subcostal plane? It is the lower end of the costal margin. So if this is the rib cage, then the lower end of the coastal margins, this becomes the subcostal plane. I think you got the idea that this is the subcostal plane. Now, why do you take reference of subcostal plane? So in this case, the answer is D. The subcostal plane remains stationary throughout pregnancy allowed because this will not move. The gravid uterus will move. As the gravid uterus grows in size, it will move up. But this remains stationary because this is a bony reference point. So that is the reason this should be taken as the reference plane because this will remain stationary. And therefore, your measurement remains consistent because you are doing it against a consistent reference. Now let's come back to the question. It says, which hormone serves as the primary precursor for synthesis of more potent androgens? I would go with DHEA only rather than pregnenolone or progesterone because that's the immediate thing. Because if you consider progesterone or pregnenolone, then there are several steps before androstenedione is formed. But with DHEA, there's only one enzyme which is there, one step which is there, and this results in formation of the more potent androgens. I hope you got my point. So that is why I will go with DHEA and not progesterone or pregnenolone. Because Sukriti and Priyadarshini, they are asking this. So I hope you got your answer now. So coming to the next question, in a hepatology clinic, a 50-year-old man with cirrhosis presents with confusion and altered mental status. The attending physician, while examining the patient, considers the underlying cause of hepatic encephalopathy. As part of the assessment, the physician reflects on the organ primarily responsible for ammonia production in the human body. What should be the answer to this clinical scenario? So which organ is primarily responsible for production of ammonia in the human body? This is a clear-cut question. How is ammonia produced? From protein? Yes, you will have easy questions also. Dr. Pallavi is asking what kind of, that kind of easy questions will also be there. Yes, some of them will be easy because they have put a clinical scenario to it just to confuse you. And you might feel that is the answer so easy. So there will be questions like that. So don't get confused. They will put in a long clinical scenario just to, intimidate you and to confuse you further. But the answer will be very easy. So you will have such questions. So ammonia is the byproduct of protein metabolism, and this occurs in liver. And also the neutralization of ammonia will occur in the liver through the urea cycle. Coming to the next question, a 29-year-old pregnant woman presents to the obstetric clinic complaining of symptoms suggestive of urinary tract infection during her third trimester of pregnancy. She reports dysuria, urgency, and frequency of urination. Again, UTI in pregnancy is a common scenario which will be asked. Upon examination, her vital signs are stable and she appears uncomfortable due to her urinary symptoms. Urine analysis reveals significant leukocyte esterase and nitrites, suggesting a UTI. Considering the pregnancy status, what antibiotics should be avoided? So in pregnancy, third trimester of pregnancy, what antibiotics should be avoided? Again, in this case, nitrofurantoin should be avoided because it can result in, what is the side effect it can cause? Nitrofurantoin. Hemolytic anemia, yes, after third trimester or second trimester, you can say rather. And trimethoprim sulfamethoxazole, should be, you give this also or not? This can cause kernicterus or hyperbilirubinemia in the newborn child. So that is why I was telling you that you should carefully read it. In this case, the answer is B plus C, because option B is also you should not give, and option C also you should not give. Amoxi and Cipro you can, but Cipro is normally avoided in pregnancy. It may affect the cartilage. What is the recommended dose? Next question. What is the recommended dose of anti-D immunoglobulin for Rh negative pregnant women before 12 weeks of gestation to prevent Rh sensitization? Again, an easy question. So before 20 weeks, so that is 19 weeks till 6 days of gestation, you should give 250 IU. And after that, that is after 20 weeks onwards, you should give 500 IU. This is as per the latest GTG guidelines. In obstetric anesthesia, what is the typical insertion site for administering the epidural block during labor and delivery to provide pain relief? So what space is the epidural block given between? Yes, it is L2 and L3. In gynecology clinic, a 30-year-old woman seeks help for irregular menstrual cycles and infertility. As the team discusses her case, the attending physician poses a question. Considering her symptoms and fertility concerns, which enzyme primarily responsible for synthesizing androgens in the ovaries, and how might its dysregulation impact her ability to conceive? So again, if we go back to the question, which enzyme is primarily responsible for synthesizing androgens in the ovary? So this is, again, you take the enzyme which is who is directly involved in production of androgens. So that is 3-beta hydroxysteroid dehydrogenase, which converts DHEAs to androstenedione. And subsequently, 17-beta hydroxysteroid dehydrogenase will convert androstenedione to testosterone. So if you again want to refer, I can take you to the picture again. So you can see that DHEA is converted to androstenedione and with the help of the enzyme 3-beta hydroxysteroid dehydrogenase. You can consider other enzymes also, but that becomes too far. 17-alpha hydroxylase, I agree that is one of the steps, but you should take the enzyme which is of the last step, the most important enzyme. So coming to the next question. What is the male counterpart structure that shares a similar function to gubernaculum in females? So gubernaculum basically plays a vital role because it helps in the descent of gonads in both males and females. In males, it will regress and it'll form what is the structure which is known as processus vaginalis. So processus vaginalis is basically a pouch of peritoneum, and this descends with the testes and it basically helps in the testicular descents, and ultimately it forms the layer of scrotum. So what is the answer in this case? It is processus vaginalis. And if processus vaginalis fails to close, what will happen? What can the baby develop if processus vaginalis isn't closed? Yes, inguinal hernia. Very good.